So can I start? Okay, hello everybody. I guess nobody introducing me, so I'll introduce myself. And everybody knows me, I'm sure. I'm a hospitalist on A1. I don't see any other doctors around, except for Dr. Mary is here. And Dr. Boyle is here too, I think. So the doctor's talk today is indications and strategies for the management of atrial fibrillation, which is a pretty common problem here at St. John's Rehab. I don't have any disclosures, I don't have any grants, research support, speakers bureau honoraria or consulting fees. Unfortunately. So the objectives of this talk is that by the end of the talk, you'll all be able to answer the short quiz that follows with a perfect score. So let's start. Atrial fibrillation is the most common heart rhythm disturbance. I've put down the ECG, but I'm not going to go into ECG findings. So when do you suspect atrial fibrillation in your patient? When you take pulse and you find an irregular heartbeat, that's usually pathognomonic, but not all of those rhythms have atrial fibrillation. The differential diagnosis is sinus arrhythmia, which is a normal rhythm that happens usually in young people with the rate changing in patients when they breathe in and they breathe out. Multifocal atrial tachycardia, which is just like ectopics from the atrium, and sinus rhythm with premature contractions, which is ectopic beats. It's quite common too. How do we diagnose this? You can diagnose it just by taking the pulse, then a 12-lead ECG. Usually you get a Holter monitor, and I'm sure a lot of you have seen us ordering one of those, and telemetry, which they have in acute care hospitals. So clinically, when they come to you, what do they complain of? Often nothing, asymptomatic. Sometimes they say they got palpitations, fatigue, shortness of breath, chest pain, shortness of breath on exertion, heart failure, stroke, TIA, or dizziness. And what is the etiology? So in hypertensive heart disease, valvular heart disease, which is what we get on A1, ischemic heart disease, cardiomyopathy, pericarditis, congenital heart disease, and especially on A1, post-cardiac surgery. The non-cardiac causes in the lungs, pneumonia, COPD, pulmonary embolus. Then you can get hyperthyroidism, everybody knows about that too. Excess catecholamines, drugs, alcohol, and significant electrolyte imbalances. So the main reason we worry about atrial fibrillation is because they cause strokes. So what is the stroke pathology? Insufficient contraction of the left atrial appendage leads to stagnant blood flow within that appendage. And so the hypothesis is the most likely culprit is embolization of the clot that forms in the left atrial appendage. 90% of thrombus is found in that area. So the reason it's so important, I'll repeat, is that it's a significant outcome of atrial fibrillation is stroke. You get reduction of blood output, stasis-induced thrombus formation in the left atrial appendage. That's number one there. Number two, the thrombus can embolize to any vascular bed, but especially to the brain. And the emboli results in a ischemic stroke, or if it goes somewhere else, some other systemic arterial occlusion. And I left this slide in even though I tried it out on the computer here, and it's meant to be a little echocardiogram, but it doesn't really work. So mechanisms of stroke in general. In this pie chart, you can see the one we're worried about here, cardioembolism, is 20% of stroke. So that's quite a significant number. Of those cardioembolic sources, 50% come from atrial fibrillation. The others come from myocardial infarct, left ventricle, the thrombus, heart disease, valvular heart disease, prosthetic valves, which we see as well. 350,000 Canadians are living with atrial fibrillation, so it's quite a significant problem in Canada. The prevalence of strokes attributable to atrial fibrillation depends on the age of the patient. For us, as you can see, when you're over 80 years old, which is a lot of our patients, it's almost a quarter. 70 years, 10%, and 40 to 50 years, 1.5%. We don't see many of those. So once you have a stroke, you've got a 40% decreased chance of being discharged to your own home in general, and that's important to us as well, and 20% chance of increased stay in hospital. 60% of strokes attributable to atrial fibrillation are disabling, and 315,000 people in Canada are living with the effects of such a stroke. This costs the Canadian economy $3.6 billion per year. 20% of these strokes are fatal, and 70% have an increase in hospital mortality. So when you first diagnose atrial fibrillation, it could be paroxysmal, meaning it comes and goes. It's not always there. The rhythm changes. Persistent atrial fibrillation is always there. And this can lead to permanent atrial fibrillation, which is usually persistent. So why is the management of atrial fibrillation so important? It's extremely common, as I told you. It can lead to symptoms. It has potentially serious consequences with the embolus and the stroke being the main one. So just briefly what the management of acute atrial fibrillation is if it's less than 48 hours. If the patient is hemodynamically unstable, and we see this quite a bit. The patient's hemodynamically unstable. They have hypotension, heart failure, chest pain, syncope, and the treatment there is usually in the emergency room with DC cardioversion. If the patient is hemodynamically stable, you can either do rate control or rhythm control. If they have significant tachycardia, go for rate control and think about what to do long-term after. The rhythm control with medications I've listed there. Usually we go with intravenous amiodarone, but those are the other drugs you can use as well. And quick anticoagulation with a low molecular weight heparin. You all know what Lovenox is. So the treatment for permanent atrial fibrillation is heart rate control. This minimizes symptoms which are associated with the excessive heart rate, and also to prevent tachycardia-associated cardiomyopathy, and that's more long-term. The other thing, anticoagulation, that's the part we're going to speak about now. When is rhythm control the preferred therapy? That's if it's a first episode of atrial fibrillation. There's a reversible cause such as alcohol-induced atrial fib. The patient is symptomatic despite rate control. The patient is unable to take anticoagulants, so therefore if they become normal sinus rhythm, then hopefully there'll be no need for it. But because I told you that it could be intermittent, usually you still need anticoagulation no matter what. If there's congestive heart failure precipitated or worsened by atrial fibrillation, or if the patient is young, and that's to avoid the remodeling that occurs with chronic atrial fibrillation. When is rate control the preferred therapy? When the patient is over 65 years old, and that's most of our patients. They're less symptomatic and they have hypertension, so the atrial fibrillation is not going to cause hypotension too much. There's recurrent atrial fibrillation. There's a previous antiarrhythmic drug failure on amiodarone or something like that. And when the patient is unlikely to maintain sinus rhythm. If they've got a huge, big, enlarged left atrium, they're unable to maintain sinus rhythm. So what is rhythm control? Is you cardiovert the patient. So cardioversion is performed as part of the rhythm control treatment strategy, and there's two types. Could be electrical, that's when you shock the patient, or pharmacological, amiodarone, IV, or those other medications I mentioned. The actual cardioversion is associated with the increased risk of stroke, and therefore you do need antithrombotic therapy when doing it. Rate control, go with beta blockers. We use Monocor here a lot, or metoprolol. calcium channel blockers, verapamil, diltiazem, Norvasc doesn't work for that. Digoxin as a last resort, we actually do use it quite a bit on A1. And then we can go with AV junction ablation plus pacemaker. So the 5-year outcomes of rate versus rhythm, 1 year, almost identical, well, it is identical. 3 years, almost identical. 5 years, almost the same. So there's no difference in death, disabling stroke, major bleed, or cardiac arrest if you're going to go with rhythm control or rate control. And sinus rhythm is maintained in only 63% of the rhythm control group. So you end up doing rate control anyway. So now the meat of it, the stroke prevention in atrial fibrillation, this is what all the pharmacists came for. Did they come? There we go. I've never been to a good talk by a physician that hasn't had a quote or a slide by William Osler. So this is my one here. Medicine is the science of uncertainty and the art of probability. So this is a good talk. So you have two goals for anticoagulation therapy: to prevent a stroke, and because you're giving a blood thinner, to minimize the risk of bleeding or a hemorrhagic stroke. Here's my Hippocrates quotes, and the reason I'm putting this in is because we're using dangerous drugs here. So this is very important. Patients fear stroke but may tolerate more bleeds, and studies have shown that a minor stroke is considered slightly worse than a major bleed by the patient. A moderate stroke is considered as bad as death, and a major stroke is considered worse than death. The older patients would rather avoid stroke and fear it more than death. And that's why we will anticoagulate even our advanced patients. So how do we choose what to do? There's 5 easy steps. Step 1, you determine the risk of the stroke. And we use the CHADS-VASc score or the CHADS-2 score. CHADS-2 more in North America and the CHADS-VASc in Europe. So the risk of having a stroke, you add them all up: congestive heart failure, hypertension, age. If they're greater than 75, it's 2 points. Diabetes, prior stroke or TIA, and that's also 2 points as compared to 1. Vascular disease, if they're between 65 but less than 75, that's 1 point. And females are high risk as well. So the total score is out of 9. 0 points is low risk, and generally you don't need any anticoagulation. 1 to 2 points, moderate risk, and more than 3 points is high risk. Once you've done that, you use the Canadian Cardiology Society algorithm for oral anticoagulation therapy in atrial fibrillation, and that's what it looks like. It says new in 2014 because that's when it came out. So if the patient is over 65, and that's most of our patients, immediately they should all be on oral anticoagulants. If they have one of the other things, and these are just the CHADS-2 risk factors, if they had a prior stroke, hypertension, heart failure, diabetes, any one of those, then they should be on oral anticoagulation. If they have none of those, but they have coronary artery disease or peripheral vascular disease, then they only need aspirin. And if all those things are negative, then it's a 0, and they don't need any anticoagulation. Then we determine the major bleeding risk. So we've determined whether they need anticoagulation. Now we determine the bleeding risk. This is also out of 9: hypertension, abnormal kidney, or liver function. Liver, because of clotting factors, is more than kidneys. Prior stroke, prior bleed, label INRs if they're on, if they are on or off Coumadin. Elderly patients greater than 65, and drugs or alcohol. This is also scored out of 9, and a high score for the HAS-BLED is greater than 3. If it's greater than 3, it does not mean you do not anticoagulate. You still have to anticoagulate. It means you can either modify those risk factors, or it's a reason for regular clinical review. So the important thing is, most times we bleeding risk or not, we still anticoagulate. Then when you're choosing what medications, you got to consider the comorbidities with the atrial fibrillation, and this helps you to choose which oral anticoagulants. So if they've got artificial heart valves, you got a warfarin, and most of you have seen the adverts on American TV where they say, tell your doctor if you have a heart valve, which I'm sure your doctor would not, but you stay on warfarin, you can't go on the newer anticoagulants. Chronic kidney disease, you also go with warfarin if the creatinine clearance is less than 30. If it's greater than 30, you can go for Pixaban or Xarelto. If they're over than 80, you would be careful of the dabigatran. If they got stable coronary artery disease, you go with aspirin and the newer ones. If they had a PCI or acute coronary syndrome, you go with aspirin and one of the newer ones. If they had a previous GI bleed, you stay away. The Pixaban is preferred. And if they have dyspepsia, you avoid the dabigatran. Apparently, it makes it worse. So then, which one to choose? The problem with warfarin is that it has limitations, as all the pharmacists will attest here. You have to monitor dose adjustments. The INR has to be greater than 2 or 3, so it needs to be monitored. It takes a long time to get within the INR range. There's genetic variations. It has higher bleeding risks, and the dietitians will tell you it interacts with a lot of food and also with a lot of drugs. I'll tell you that. So warfarin or Coumadin is the cornerstone of therapy. If there's 51 ischemic strokes per 1,000 patient years, warfarin will prevent 28, and there'll be 11 fatal bleeds. Aspirin will only prevent 16 with 6 fatal bleeds. The risk reduction is close to 70% if you do not anticoagulate. And if you just use aspirin by itself and you used warfarin, there would be a 40% risk reduction. So aspirin by itself usually is not great. And this just shows you the previous slide that I had in pictures. It's just more or less the same thing. Lucky for us, that's a thumbs up. We have new treatment options for to use instead of Coumadin when applicable. Who stays on warfarin when the patient is stable and INRs are easy to control? If those newer medications are not available, this doesn't make any sense anymore because they're all available here now. Cost is covered by ODB with limited use form. If the patient's not likely to comply, some of the medications, the new ones, are twice a day. If that chronic kidney disease, as I said, less than 30 GFR, and valvular heart disease. These are all the newer medications, and all this chart is showing is that these newer medications are equal to or superior to Coumadin. And the important one to look at there is the intracranial hemorrhage rate is much less in all these newer medications than Coumadin. So the Canadian Cardiology Society recommends that when you're using oral anticoagulants that you use these newer ones in preference to Coumadin. So with everything we've already said, you have to consider the risks and benefits of therapy. So in summary, the newer oral anticoagulants offer a huge advantage over Coumadin and should be used in preference except when contraindicated. There is substantially decreased risk of intracranial hemorrhage with the newer ones, no INR monitoring. It's as good or better stroke prevention, similar or less major bleeding, and no food or drug interactions. Well, I wouldn't say no, but less. You should consider the patient characteristics when choosing the medication, and the last thing says that some patients won't need anticoagulation at all. So a EP cardiologist made me put in the following slide that he, yes, this is his way of saying practical decisions and options for patients with atrial fibrillation. He chose a happy face, a sad face, and an angry face. happy is the asymptomatic older and sedentary patient with no hemodynamic compromise, and these are our patients. The sad one is a young patient, more active and getting some hemodynamic compromise. And the angry one is the severely symptomatic younger patient, no heart disease, no hemodynamic compromise. So the older ones, our patients, rate control and the novel oral anticoagulants. The sad ones, rate control or rhythm control, and the novel oral anticoagulants, and the angry ones, rhythm control. So they go back in sinus rhythm. So in summary, atrial fibrillation is a common important cause of stroke, important at St. John's. The stroke risk should be assessed for each atrial fibrillation patient, and the appropriate anticoagulation treatment should be decided on as per all those guidelines that I went for. They were in 2014. And the bleeding risk should be assessed for atrial fibrillation, and the bleeding risk factors should be modified. The most important thing is the risk of bleeding very rarely outweighs the risk of stroke. Okay, instead of you asking me questions, I'm going to ask you questions. So if you have a telephone, go out to that website, and I hope I know how to do this. There has to be at least one person doing it, otherwise it won't work. There we go. I'm waiting for players. Ah, okay, good. Who's Batman? Come on. Okay, we've got a few. We're ready.
Let's take a question.
What are the most common treatments for permanent defibrillation? Heart rate control and coagulation, heart rate control and exercise, coagulation and hormone therapy and exercise. Whose MG is winning? No. What is the most prevalent cardioembolic source? Acute MI, prosthetic valves, valvular heart disease, non-valvular atrial fibrillation. Oh, that's pretty good. Well, Dr. Mass, coming second. Which therapy helps to reduce the risk of stroke for a patient receiving cardioversion? Radiation therapy, chemotherapy, antithrombotic therapy, or immunotherapy? Oh, I made it too easy. How many Canadians are living with atrial fibrillation? Dr. Maz on the cardiac unit. Which type of scoring is used to determine stroke risk? APGAR score?
You should go like Jeopardy or something.
Hasbled score, CCS algorithm. Oh, Dr. Maz. What is the site where 90% of thrombus is found in AFib patients? Right atrium, left atrial appendage, left atrium, ascending aorta. And I didn't give her the answers before. So if a nurse, therapist, dietitian reports a patient to me with atrial fibrillation and a heart rate of 168, what do I do? Immediately call 911 and send the patient out. Tell them to go back and do an old-fashioned manual apical heart rate, reach for the defibrillator. And I'm sure everybody on A1 will know this answer. Our electronic monitors here sometimes overread the atrial fibrillation patient. And that's if any of you remember how to do a old-fashioned manual apical heart. Oh. If someone is DNR and palliative with atrial fibrillation at St. John's Rehab, should we still put them on anticoagulation? No point, no active measures. Yes, remember most patients fear stroke more than death.
Oh, geez. Take the next question off.
Even if you don't answer the next one. Which unit at St. John's is AFib most prevalent? A1 and A2, A4 and A3? People might argue with this. The most important question coming up, was this number 9? On which unit at St. John's Rehab is the most fun to work? A1. And that's the end of the talk. Any questions? Okay, well.
Reversible? Like, once you have it, is it like something you're going to have the rest of your life? Can it be reversed with your rate control?
So a lot of our patients that have cardiac surgery, they arrive, because after cardiac surgery, atrial fibrillation is quite common. They arrive anticoagulated on Coumadin, and the instructions to us are leave them on anticoagulation for 3 months. They go back to the cardiologist and cardiothoracic surgeon, and they check the rhythm, and if they are in normal sinus rhythm, then we can stop the anticoagulation, but generally besides that. So yes, those ones are reversible. Okay, thank you everybody.